Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk.
This program is presented by Medscape Education Global.
Hello, I'm Alice Chang, endocrinologist at the University of Toronto in Canada, and welcome to this program titled Advances in the Pharmacologic Management of Obesity, Looking Ahead to EASD 2025. Joining me today is Professor Arya Sharma, Professor Emeritus of Medicine, University of Alberta in Edmonton, Canada, and an internationally recognized expert in obesity medicine. Welcome, Arya.
Hi, Alice.
EASD 2025 is just around the corner with lots of exciting data to come in both diabetes and obesity. So today we're going to talk about where we stand with the guidelines for diagnosing and treating obesity and look ahead to what new data will be presented at EASD 2025. So with that in mind, Arya, why don't you get us started? Could you tell us a bit about a couple of recent consensus statements and guidelines for managing obesity, namely the Lancet Commission document and the European Association for the Study of Obesity, or EASO, guidelines?
Well, Alice, as you know, in obesity, we're still kind of struggling with the definition of obesity and how do we make the clinical diagnosis of someone having obesity? Because so far we've been relying very much on body mass index, which we know is a measure of size. It's not actually a measure of health, and so it's not the best basis for a diagnosis. Now, there was a lot of excitement earlier this year when there was a paper. There was a kind of consensus paper that was released by a Lancet Commission that really introduced a new term into the discussion. And they talked about preclinical obesity and actually introduced the term clinical obesity. And the basic idea here is that, yes, you can have people with excess adiposity, but what defines clinical obesity is really the demonstration of altered organ function. So it's not enough to have excess body fat, but you really need to demonstrate that this excess body fat is in some form or fashion altering organ function and ultimately leading to end organ damage. So the so it's not enough to have body mass index or even other anthropometric measures like waist circumference, etc. What you really have to do, you need to have both the anthropometric criteria, but you also need clinical criteria. And as we said a couple of years ago in the Canadian obesity guidelines, really when we talk about obesity, it's a clinical diagnosis. You have to actually see the patient. You've got to take a history. You've got to do maybe some lab exams, and then decide whether or not this person actually has the disease that we now call obesity. Now, there have been other guidelines, and one of them is the European Association for Study of Obesity, which presented at least their preliminary guidelines last year. And here again, we see that the diagnosis is not based only on body mass, but we need both anthropometric. There's an anthropometric component to this, where we look at body mass index, but we also look at waist hip ratio or other anthropometric measures. But there's also a clinical component to this, where we have to look at the medical sort of the medical history of the patient. There's a functional domain, and we of course know that obesity can very often lead to mental health issues. And so so once again, the diagnosis of obesity, just to summarize, is a clinical diagnosis. You have to see the patient, evaluate the patient, and then make up your mind whether or not this patient actually has the disease that we now call obesity, and whether or not this patient is someone who's likely to benefit from treatment.
So that's fantastic, Arya. Thank you so much for summarizing that. And I think the big take homes for me as a non-obesity expert, quite like yourself, is to say it's not just size. I really liked what you said about how BMI is just a measurement of size, but it's actually about health and clinical outcomes of that may be related to the size, shall we say. So then there's a size criterion, but there's certainly the health piece that's absolutely critical. So that's really helpful. And then also that there's many different ways to manage obesity one of which, of course, would be from a pharmacotherapy perspective. So, with that in mind, let's take a look at some of the relevant data presentations that are planned for EASD and provide a little bit of background on each of them. And obviously, there were a lot to choose from, so we kind of had to be a little bit picky. So, why don't I go ahead and start and talk about one of the compounds that we're going to hear more about at EASD. So, to start off, I'm going to talk about Step Up. So, Step Up is actually a study of a higher dose semaglutide. We're already used to semaglutide up to 2.4 milligrams a week, but now the question is the efficacy of up to 7.2 milligrams a week. And there will be some data that will be presented at EASD 2025 on semaglutide 7.2 milligrams. What we know so far are some of the data that were presented at the ADA in 2025, which was looking at a 72-week randomized double-blind trial of individuals randomized to titrated up to semaglutide 7.2 milligrams versus that of 2.4 milligrams once weekly and followed out to 72 weeks. And what we know from the data that were presented there was that the 7.2 milligram dose was able to be more effective in terms of the magnitude of weight loss compared to that of the 2.4 milligram dosage. And when looking at weight loss thresholds and people achieving different levels of weight loss, not surprisingly, the 7.2 milligrams was more effective at the higher thresholds of weight loss. At the lower thresholds of weight loss, both doses were fantastic. So, we're talking about 5% weight loss, both doses were able to achieve that quite readily. Similarly, with 10%. But when you get to 15%, 20%, 25% weight loss, which I have to say for me is incredible that we're having conversations about 20%, 25%, and down the road, 30% weight losses. I mean, that alone is incredible. But that's an aside. The 7.2 milligram dose was more effective in achieving those levels of weight loss. But then, of course, we got to talk about side effects. So, from a side effect perspective, the gastrointestinal side effects were, of course, prominent as expected for semaglutide or its class of medication. But interestingly, there were more dysesthesias, which is a word we need to get more comfortable pronouncing. So dysesthesias would essentially be, I guess, funny feelings is probably the best way to describe it. Usually on the skin that people are experiencing, and there were more dysesthesias felt by the semaglutide 7.2% milligram group. So I think it'll be interesting to get more data looking at that particular adverse event. So that's the wrap up on the semaglutide 7.2 and something to look forward to. Aria, let me pass it over to you.
Yeah, I mean, I can just share my excitement about the 7.2 because it's good to see that you can actually increase the dose and you still get additional effect with not a great increase in yeah, with not a great reduced tolerability. Now, I want to turn our attention to other studies that I think we're looking forward to, and that is data from Redefine 1 and Redefine 2. These are two clinical trials that look at the Kagrulinide, which, as you know, is an amylin agonist or analog. And we have the Redefine study that's in patients with obesity who don't have diabetes. It's a 4-arm trial. The comparators are Kagrulinide 2.4 versus Semaglutide 2.4, and then the combination Kagri-Sema, which of course we're all very excited about. That's a placebo-controlled trial. And then there's going to be Redefine 2, which is for people who have obesity and diabetes. And this one has just 2 arms. It's placebo versus Kagri-Sema. And both studies are obviously going to be pretty interesting to watch and see what happens. Now, we've seen results already presented at ADA, and it was clear in Redefine 1 that Kagrulinide alone is effective. So you're getting about 10-11% weight loss. When you compare that to Semaglutide, you're getting about 16% weight loss. But when you combine the two, you're getting almost 23% weight loss. So I think that's pretty exciting. In Redefine 2, just as a reminder, those are the folks who only had diabetes. It's a two-arm study. Clearly, CagriSema was far more effective than the placebo arm. In fact, you got almost 16% weight loss, which is actually pretty good for a trial that you're doing in people with diabetes, because we know that generally speaking, uh, we tend to get less of a weight loss response in individuals who do or who have diabetes. Now, the most common adverse events were, we always have to say, the usual, which means some nausea, some vomiting. There was a bit of constipation. There weren't a lot of AEs that led to discontinuation. And so I think it's fair to say that the treatment was reasonably tolerated.
And I too share the excitement around CagriSema, and I have to say the um, the idea of combining different modalities is becoming uh, much more much more commonplace, I guess, in especially in the obesity space. And I think we're going to see more and more of these types of combinations. And the one that we're already used to, I guess, now would be the GLP-1 receptor agonist combination, which of course is a tirzepatide. And the study that I'm very much looking forward to at EASD 2025 are the results of the Surpass CVOT, which is the cardiovascular outcome trial for tirzepatide in those living with diabetes who have established atherosclerotic cardiovascular disease. Before we get into the results or what we know about Surpass CVOT, may be helpful to set the stage to say that there was a pre-specified meta-analysis of cardiovascular events from the Surpass program. So the Surpass program was a phase 3 clinical trial program of tirzepatide in diabetes, not designed to look at cardiovascular events, but designed to look at metabolic effects. That there was a pre-specified meta-analysis of the events that did occur in those 7 Surpass studies. And what was found was at least safety or non-inferiority, I guess we could say. But the number of events were obviously very small, and this is not the kind of analysis that would help us decide whether or not tirzepatide is helpful from a cardiovascular perspective. But what was required, of course, would be a properly designed cardiovascular outcome trial, and that is Surpass CVOT, which is the first head to head cardiovascular outcome trial of tirzepatide with an active comparator of dulaglutide, which is exciting because we already know that dulaglutide, a GLP-1 receptor agonist or monoagonist, does in fact have cardiovascular benefit in those living with type 2 diabetes. So it's a head-to-head study of tirzepatide versus dulaglutide in those living with type 2 diabetes and established atherosclerotic cardiovascular disease, over 13,000 individuals. We will see the full results at EASD 2025. But what we have at this point are top line results. Now, it was designed with the primary endpoint of the classic 3-point MACE, so non fatal MI, non fatal stroke, cardiovascular death. And primary endpoint was that for non-inferiority and then, if possible, superiority. What we know is that non-inferiority was established, hazard ratio of 0.92. Superiority was not established, but we also have some secondary endpoints that were announced within the top line results, and all cause mortality was statistically significantly reduced in the tirzepatide group. The slope of decline in the EGFR was also lessened in the tirzepatide group. And as expected, the amount of A1C reduction and weight reduction was much greater in the tirzepatide group. So the fact that we know dulaglutide is effective from a cardiovascular perspective and that tirzepatide was non-inferior to that, I think gives me reassurance that yes, in fact, tirzepatide does bring some cardiovascular benefit. But of course, I look forward to the full results to be presented at EASD 2025.
Well, I was certainly excited when I saw the top line results. And I think very soon in obesity, we're also probably going to have to do trials against an active comparator uh, because, we already have established the benefits, say, of semaglutide, and we look forward to the results of the tirzepatide the cardiovascular outcome trial in people who have obesity but no diabetes. And that's going to be very exciting. So, there's so much exciting stuff to talk about. I mean, one of the things I'm really looking forward to is going to be looking at the results of the Attain trial. Attain is a trial that was done with the oral orforglipron, and as you probably know by now, orforglipron is a small molecule. It's an oral GLP-1 agonist, actually the first in class, if you so want. If you're not going to count semaglutide, because orforglipron is a small molecule. We have an oral version of semaglutide, but that's still the large molecule. I mean, that's still the peptide. So we're going to see Attain 1, and what we expect to see there, of course, are the effects on all of the parameters that we are interested in besides blood pressure. And of course, what we're interested in seeing are all the effects of orforglipron, not just on body weight, but on all of the other parameters that are of importance to people living with obesity. Now, we have already seen results of orforglipron in individuals with early type 2 diabetes, and those results were presented at the ADA. I'm talking about Achieve One, and this, of course, makes us very enthusiastic uh, in our hope that we are going to see good results and good outcomes, with this molecule in people living with obesity.
That's great. And I think orforglipron being that small molecule and then not having those restrictions around water and food, I think we're hopeful that it's going to show some exciting results. The next molecule that I want to talk about is amicretin. This is another word I'm going to need to get comfortable pronouncing. So amicretin is actually a unimolecular GLP-1 and amylin receptor agonist. So it's unimolecular. So different from that of Kagrisema, which are two separate compounds that are simply being injected together, if you will. Whereas the amicretin is a unimolecular dual receptor agonist. And what we're going to see at EASD will be some more data from the amicretin phase 1b 2a study. We already saw the results of their phase 1b/2a study that was presented at ADA and then ultimately published in July 2025. And because it was an early phase study, it was primarily looking at tolerability and then also some dose ranging as well. What was exciting about this once weekly injectable compound, though, was that from a tolerability perspective, it was reasonable, but there was quite a high frequency of GI side effects. So I think one of the things that will need to be sorted out is how best to escalate the dosing, the timing of it, in order to try to minimize that. Certainly before it comes out into clinical practice. But there were no other surprising side effects to come out from this particular trial. But what's also exciting, of course, is the magnitude of weight loss that was achieved. So at the 60 milligram dose of amicretin, they were able to achieve a 24% reduction in body weight. And then that lessened as the dosage of the amicretin went down. So I think this is more of an exciting area just to keep an eye on. And at EASD, for example, we're going to see some data from the renal subgroup within the trial. So I think, interesting things for us to keep an eye on. So Ari, at the beginning of this, I mentioned that we had to pick and choose, and that there's a bunch of other stuff that will either be presented at EASD or, frankly, just other stuff in the chronic weight management space. So, can you just name a few of the other compounds that we have not had a chance to go into depth in this particular session?
Well, Alice, as you know, I mean, clinical trials are now chock full of other compounds, and there's so many of them. Some still only have numbers, and some have, as you mentioned, names that we're going to have to learn how to pronounce. At least if if these compounds make it to clinical practice. Uh, just to mention a few, and this is really just a random selection. I mean, there's probably going to be more data on bimagrumab and sema. The Believe trial is the trial that's looking at that. There's going to be more data probably on maritide, which is the long-acting GLP-1 agonist, and then we have survodutide, and we have, of course, retatrutide, which is the triple, the triple agonist. So There's lots and lots of stuff to come, and I'm sure this is going to be a very exciting meeting, and there's going to be a lot for us to catch up on as far as pharmacotherapy for obesity is concerned. So, just to summarize, I think it's going to be a very exciting meeting. I know this is a diabetes meeting that we're going to, but it just shows of how much interest there is, even in the field of diabetes now, with all these exciting obesity medications coming up. Because, as many of us believe, obesity, if you can cure obesity, then uh, a lot of type 2 diabetes is just going to take care of itself. At least that's my opinion as an obesity person. Uh, One of the things that I think we're going to be seeing is a lot of discussion about these compounds and finding a role for these compounds in clinical practice. I think that's really something that we are probably all going to be looking forward to. It's going to be an exciting meeting. I look forward to catching up with a lot of colleagues from all over the world. Vienna is a great place for a conference. Thanks, Alice, for the great discussion, the great presentation. We'd like to finish off by thanking you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. And we look forward to seeing you again after the meeting.
This program is presented by Medscape Education Global.